Seems to start working now. So you should get a notification here on your screen. Does everyone see that? Is there a little pop-up for you? No, but I think, yeah, we are live now.
Yeah, there is live streamed.
It is, right? Perfect.
Yes.
Okay, so let's make a start. Welcome, everyone. It's great to see that lots of you were able to join today for another Open Digital Health research seminar. My name is Sebastian Potthoff. I'm an assistant professor at Northumbria University in the UK and one of the directors of Open Digital Health. And yeah, we have these conversations once a month now on a topic around digital health, you know, where we invite prominent speakers in the field and try to have some conversations around relevant topics. And today it is my absolute pleasure to introduce Professor Jane Walsh. Jane is a professor of health psychology and a director of the Mobile Technology and Health mHealth Research Group in Galway, where she leads an innovative program of research in the area of personalized connected health. Jane was awarded the President's Award for Research Excellence in 2020 and the Dean's Award for Research Impact also in 2020 in recognition of her work. And her projects include over 10 million euro as a PI and or co-applicant, including Horizon 2020, Marie Curie, and a range of other sort of funding bodies. So we're very lucky to have Jane with us, such a prominent person in the field. And Jane will be presenting today on the topic of trust and technology terrorism in medicine, the role of psychology in the digital transformation of healthcare. So it's my very pleasure to have you, Jane, and yeah, I'll hand it over to you, and we'll first do the presentation, and then afterwards we will have a conversation. So just keep your questions for the end, and then you can also post them in the chat. So
thank you very much, Sebastian. Thank you. And thank you everyone who's come today. And it's an absolute pleasure to be here, and well done on the work you're doing in the Open Digital Health. It's fantastic and absolute delight to be here. And thank you for that lovely introduction. And I wasn't sure how much you tell them, but that's it summarized. And the funding has gone up since the 10 million. That's the good news, and great news for anyone here who's in health psychology, because in fact, health psychology is gaining more and more traction in the field of digital health now, and is really a key player across all dimensions of what's being done in the field. So I suppose we're all aware now of the fact that even if we try to ignore technology, we cannot. We are living in the age of a digital revolution. I think in 10 years' time, they look back and say that wasn't a revolution, now is a revolution. The rapid change of tech development is breathtaking. Most of us are barely getting the hang of things that came out 5 years ago, and already what's coming straight onto the field in innovation terms is beyond our understanding. So we all were forced to use technology during the pandemic. And this was a huge advantage for digital health in many ways, because it accelerated the mainstream use of technology across a broad range of activities, but specifically in health, it became critical. What we know is that all tech developments are driven by industry. There's a huge market there for technology innovation, not just in the area of healthcare, but of course, healthcare is a big market because, as we know, we are an aging population, where there's a rise of chronic diseases, there's burden on the healthcare system. And so any technology that can be used to increase efficiency and empower patients is now golden and of high value. So it's really nice for us all, and many of us here today are probably psychologists, to reflect on what are the trends, because many of us, as we learn about, theories of health behavior and different styles of research, the last thing we're doing is reading technology magazines. It's often what we sort of see passing in front of us that we're aware of. So let's just think about what's coming out now. What are we doing? Well, wearable devices are something that have been on the market for a long time, and most of us now have them. 10 years ago, really, they were very new to us. So whether it's your Garmin watch, Fitbit or Apple Watch, even carrying your mobile phone, those nice rings that are meant to detect your mood, items of clothing that are sensors that perhaps pick up heat, stress, sweat, smart glasses. So some of us have some of these things. Other ones we're thinking, there's no way I would ever use those. Big data, of course. And really now everybody knows big data feeds straight into artificial intelligence. We release so much data about us into the cloud in every activity we do, from tracking with our mobile phone to where we upload pictures relative to locations, to how we use our credit card on our phone. We're predictable little creatures that are being tracked with our own devices and with sensors that exist out and about already. And of course, this data feeds into artificial intelligence. Now, even 6 months ago or 12 months ago, if I mentioned artificial intelligence in a talk like this, most people would be slightly unclear as to what it means. But now things like ChatGPT are getting so much attention on mainstream media that everybody knows that artificial intelligence is what drives these interactive information parting sessions with all kinds of devices, from chatbots to social robots and so on. Mentioning social robots, many of us still, when we think about robots, we think about, sci-fi movies. We don't really think we're ever going to encounter them in our daily lives. And in fact, most of us will not have encountered a robot in any social domain in our daily lives. However, there's actually quite a wealth of research on the use of social robots in many settings in health domain, particularly with older patients in either our old folks' homes, patients with dementia, where the research shows very positive reactions to the use of social robots to combat loneliness, to assist in memory tasks. And this is an area that actually is not going away anytime soon. Another trend, it's been around a long time, is virtual reality. And most of us have come across this, either in terms of how we use computing games or having had a go at an immersive virtual reality experience. And more recently, you may have noticed on your phones that you can have augmented reality when you're looking for directions. Nice blue arrows appear on your screen to help guide you. So this is something that is very useful. Another area we've actually started doing a bit of research in is the use of virtual humans. So this is a group that are created by Soul Machines in New Zealand. And we've recently collaborated on a few projects with this group. They're a little bit creepy to most of us ordinary people. The idea that you have to speak to somebody who's not real and have a conversation with them, still something that we're not very keen on, but it's something that is gaining traction rapidly for maybe straightforward types of interactions that don't require a healthcare professional, simple educational tools, maybe simple low-level counselling. These could be used to take burden from the healthcare services, and they're being explored as we speak. Underpinning all of these huge changes in technology is what's going on with 4G, 5G, and they're now talking about 6G. And what that means is that the speed of processing is multiplied by at least 100. And what does that mean to us ordinary users of technology? What it means is we can have live, moment-on-moment interpretation of data, immediate response, and AI-developed algorithms with the flick of a switch. For first responders, this would mean using, for example, augmented reality goggles. You could get information either from AI, previous programmed information sites, or from clinicians who are remotely looking at the same scene that you're looking at and giving immediate advice. Theoretically, this allows access to the best healthcare no matter where you are. And it also allows for highly personalized healthcare. So these are big advantages. So let's all just take a pause for a moment. Because as we go through these different types of developments, some of us will be sitting very excitedly, rubbing our hands going, that sounds amazing. But most of us can feel a growing sense of horror at the idea that, you know, humans may be taken out of the equation, that AI will take over, that we'll be controlled by our own data, and that there's no regulation of rogue industrial partners that might abuse this access to data. If you talk to ordinary people and you say the robots are coming, you'll be talking to virtual humans. The reaction of many is fear, concern about being monitored, controlled, brainwashed. Anyone who's following the conflict at the moment in the Gaza Strip in Israel will find that it's really difficult to get accurate information on what's happening, because we're being fed all kinds of misinformation on the normal streams we might access. And so this is something that people are sometimes oblivious to, sometimes aware of, and there's a growing sense that we're not in control now of what we're receiving. And this is not something that we want. Patients are kind of saying, well, I don't expect to go to hospital and not see a doctor, be treated by a robot. Where's the empathy? Where's the love? Where's the care? We're not the only ones. People working on the front line are worried that robots will take over their jobs and that they'll become redundant. But actually, when you analyse people's time and how they spend it in the healthcare service, much of their time is working at a level below their top skill level, below indeed their pay grade, and that if we had assistance, robotic or otherwise, to remove some of the lower grade tasks, in theory, more time can be spent with patients. So this is something that would work better for everybody. Now, all of this work and talk around you know, the importance of psychology and human-centered design is not just from one discipline. The World Health Organization, going back to their digital health strategy from 2020 to 25, said that their vision is a person-centric digital health solution. And this is where psychology comes in, because if it comes to understanding people, there's no discipline better to understand all dimensions of barriers, motivators, mechanisms for improving adherence, and positive impact of research. So that means that if we're going to have a safe and effective digital transformation of healthcare, building in some of the trends we mentioned there, that we need a multidisciplinary approach. It cannot be industry driven. It cannot just be the medics. It needs to be a team, including patients, at the center of design, where we look at developing technology that's impactful, acceptable, and is effective. And of course, in the middle of that, we have the psychologists with our expertise. Now, anyone here who's a health psychologist will be thinking, well, I've not managed yet to convince industry or other people that they need my contribution. In fact, I'm not even sure how I can help really. I've all this knowledge, but it seems like a bridge too far to embed psychology in the center of it. But it's not as hard as we think. And over the last 10 years, pretty much all of my work has been with psychology, technology, and medicine mingled together. And what's become very apparent is that psychology isn't just an add-on or a bit player. Psychology has a critical role, a central role, I would say, in the creation of this type of future for technology design. So I just summarized some of the key areas that we not only contribute, but lead on. What about the acceptability? So we're very good at those kind of research studies, qualitative and others, where we get the key stakeholders or patient groups together. We talk about where the future is going. We look at mechanisms that are acceptable. Then we look at engagement during the development and co-design process. We look at what kind of tools are workable. What we found is simplicity is often the key. So technologists will have bells and whistles and lots of fancy designs and buttons, and it's too much. Even for the tech savvy people, they need something very, very simple. They often need it focused on a single behavior or single goal, and then it's very effective for that particular function. and then to see whether or not it actually works. So what is the purpose of this technology? Is it to get people to take their medicine? Is it to encourage people to increase their step count? So what are our measurable outcomes and how can we assess them? And another area which includes all of these that we're really excellent at is methodologies for all of these. We have expertise in qual and quant measures and survey, randomized control trials, systematic reviews. We're really good at understanding what's required for any type of technology for target group. And of course, a critical component of everything we do in the area of health is around behavior and behavior change. When we look at what are the causes of most of chronic disease or even issues around chronic disease management, it is the things that we do, our behaviors. And so that's an expertise that no other discipline has like us. Anyone who working in the sector will tell you that health behavior is complicated. So you can get people running, but maybe they won't give up the cigarettes. You can get people cutting down on sugar, but maybe they won't run. So what you're looking for is the high risk, high motivation, and then developing an intervention that's personalized and is achievable for the individual. There's no one size fits all. And technology is actually a magnificent vehicle for us to personalize our communications with our participants or patients around what works for them, training them up on it, and then following up to see, is this helping them? And if not, pivoting them onto another path. So I love this quote from Desmond Tutu, which is, there comes a point where we need to stop just pulling people out of the river. Some of us need to go upstream and find out why they are falling in. Who better to do that than psychologists? And you don't even need to be a health psychologist, but the focus on health behavior becomes really useful there. If you talk to technologists 10 years ago, they may have used some user-centered design, but many of them were developing technologies without ever communicating with a medic or a patient or the public. And then they'd scratch their head when the technology wasn't being used or people said, that's terrible. And they realized that what they had to do was go back and get feedback, work with key stakeholders. And so this is, again, a key role for psychology. Now, I just thought I'd tell you about a couple of research studies we're doing where we've looked at some of the trends. And we've had a lot of fun trying to use these technologies with different groups to see if it works at all. And, what would we recommend in the future? So one of the studies we did was looking at a humanoid robot. There he is in the picture. And you can see he's got an iPad built in. And we wanted to see, would he improve patient knowledge? So we wheeled him in, we called him Dave, to the waiting room of a diabetes clinic where patients could interact with him and his screen and learn a little bit about a specific element of diabetes self-care. For example, administering insulin or dietary related component. And they would have this before they went in to the doctor. What did this do? It gave a little bit of, alleviated some of the boredom of patients in the waiting room. But more importantly, it cut down on the amount of time that the doctor needed during the consultation to go over things that he didn't need to be doing, but were time consuming. Instead, he could focus on personalized agenda for the patient's healthcare. In other words, operating at his highest pay grade with the patient and increasing efficiencies. Now, what we found, in fact, is that patients really liked Dave. They thought he was great. They didn't mind him. We thought maybe they'd find it offensive or they wouldn't learn. But not only did they like him, but it also increased their knowledge. That was a very simple study, just a before and after, not a full trial. And it was really a feasibility test and some very positive, pleasing results. But as we all know, improving knowledge is one thing. Changing behavior is a whole other ball game. So during lockdown, we had more fun with Dave. We put Dave in the waiting room of the hospital across the road from the university. And we did a little observational study. And you can see that these studies are published and you can have a read of these in your own time. In our observational study, we had standard observation of people entering the hospital foyer, would they sanitize their hands? The experimental condition, if you like, was Dave, who is a military grade robot. So when somebody entered the foyer, he would go, hello, would you like to wash your hands today? And if somebody went, yes, he would say, the sanitizer is over on the wall. But if somebody said no, he would go, oh, sad face. So a little bit of emotional blackmail there. What we found was a significant increase in sanitizing behavior, hand sanitization, when Dave was present. So a tiny little simple study with positive effects. So again, these are tools that our perception, maybe they're not going to work. Reality is they're being more favorably and effectively integrated than we might have expected. So I just want to tell you about another project that we're working on, because one of the challenges, of course, with the use of technology in healthcare is accessibility, equality of access, and we're all very aware of the urban-rural divide. So in Ireland, there's a small little island called Clare Island off the coast of the west of Ireland, only of 140 inhabitants. There's no Wi-Fi on the island. And if these people, who are an aging population, wish to visit a doctor, they have to get a boat across the water, drive for an hour plus to go into hospital to visit the doctor for 10 minutes, and then repeat the journey back. And you can imagine if they're not well, or if it's just around management of chronic disease, this is a significant amount of time and cost for them, and quite a stressor. So we're in a project funded by industry, which is Cisco and also Science Foundation Ireland, to develop remote care by building a mast, putting in 5G fluid mesh Wi-Fi to the island, having remote consultations, giving all of the members of the island Fitbits to track them, and then also using AI to help integrate their data into a decision-making tool. There's a picture of all of us looking very well. So we went over on a couple of site visits, because a really important part of this, as you can imagine, is public and patient involvement. Small island, rural community, not used to a bunch of academics in suits coming over. So the first time we went over for a stakeholder meeting, we noticed people running up the hills and back into their houses. And we asked, our contact on the island, we said, is everything okay? Why are they running away from us? And they said, well, they've seen your man over there wearing a suit and they think it's the tax man, so they don't want to meet him. So we started to recognize early on, to engage, we needed to understand everything about island life. So here's us in a beautiful island on a nice sunny day. And you can see the picture below is the public and stakeholders meeting, where we had a chat with the community. We told them about the project. And then we said, put your hands up. What do you think about, participating in this? And no hands went up. And we went, we said, could you explain to us, what your reticence or what your concerns are? And they said, we're very worried after what you've said, that you're going to take our doctor and nurse off of us and send out some robots and other things, and we will be worse off. And we realized that, we hadn't communicated clearly and in recognition of the things that were important. So after a big, long discussion with them saying, well, no, we're actually going to enhance existing care. You're not losing anything, you're gaining. When we asked for a show of hands, again, all hands went up for participation. And that is the only way you achieve success with a project like that. So Clare Island may have been challenging, but we in Galway are part of a partnership which is funded by Horizon Europe, 8 million euro, which is looking at an even more challenging population. And they are rural areas in Ethiopia and Madagascar, where the purpose of this research, which is led by the Louis Pasteur Institute in Paris, is to try to eliminate malaria by testing and treating in rural areas. As we know, malaria is carried by mosquitoes that bite one person who, if they have malaria, that is transmitted by the bite of a non-infected person by that same mosquito. So the idea there is eliminated from everybody's bloodstreams, and the mosquitoes can bite away, but they're not transmitting malaria. So it's a huge challenge. The only way you can eliminate malaria is through taking a certain medication, which wipes it out of your bloodstream. But often people carrying malaria are asymptomatic, it's dormant. And also so they don't feel sick. It's like blood pressure, asymptomatic. Also, they have to take medication that may make them feel nauseous, or they have to take it with food, and they may not have much food. So this is a very challenging project. And Galway's role, which is psychology driven, is to look at community acceptability of taking this medicines and this testing and treatment protocol, but also to develop a mobile technology to be used by healthcare workers on the ground in these rural areas for the testing, treatment, and decision-making around this malaria elimination strategy. So as you can imagine, in this project, University of Galway School of Psychology are one partner. All the other partners are malaria scientists, or pretty much basically, and a technologist. So for us to be included in a project like that is really fantastic and very challenging. In May, we went over, so here's our partnership. If you have a look at the map there, there's Ireland out to the far left-hand corner, lots of European partners, and then the African partners in Ethiopia and Madagascar. So our role, as I mentioned, is really around the stakeholder perspective. So anyone who's here, unless you're from Ethiopia or Madagascar, you've probably not been to those places. So we don't have contacts, we don't know what the cultural barriers might be. We're white Western people going into that environment to get people around a table, to communicate in a language that we don't have, to develop a strategy around digital health when most people don't have access to computers and not many will have phones. So you can imagine the challenge. So Galway went over in May. We went over, 4 of us from the School of Psychology, and we conducted collective intelligence workshops with partners in Ethiopia and Madagascar. And here's some images from that work. So very like this very structured qualitative work many of us would typically do. This collective intelligence is a very focused, guided type of workshop where we pose a series of questions and we ask people to write their thoughts as a group, agree and rank. And then we do a sort of all room consensus building exercise. And then from there, we develop a document, a protocol. So we've developed 2 deliverables on this project. One is the collective intelligence barriers and facilitators to testing and treatment of malaria using digital health in Ethiopia and Madagascar. And the second document we produce is a digital health strategy for testing and treatment of malaria. And both of those, well, one is publicly available now, actually, and the other one will be quite soon. So again, I suppose I just want to reiterate to everybody who's here, they are psychology-led exercises, psychology-led. And, you know, every time I think about that, I'm really very proud of our discipline for the contribution it can make to what is a global problem in a region that is not well known to us. So they're just little samplers of some of the work we do. They bring us really deeply out of our comfort zone. And I think psychology has enormous capacity to do that because we have the knowledge, the tools, the skills, and we're very good at working across disciplines, especially the health psychologists, because we've been doing it from the very beginning. So what do we see for the future in this area? Well, at the center is the patient or the stakeholders, and we need to work with them from very early on. And we need to merge that kind of input with data. We need to become comfortable with big data. We need to become comfortable with the idea of just-in-time adaptive interventions, AI-powered merging of our data, personalizing it for individuals, cultures, regions, specific problems. We need to be very mindful and educate ourselves on issues around regulation, data, safety, privacy. And that's very difficult, but we need to do it. And finally, we need to develop and foster a synergy between multiple disciplines, with the person at the center of design through all stages of design, implementation, and evaluation. And psychology is very strongly placed to do that, because that's something that we're all doing already. And just to conclude, after our recent trip to Africa, this proverb, I think, summarizes where the future of technology and health is going. If you want to go fast, go alone. If you want to go far, go together. Thank you very much for your attention.
Thank you very much, Jane. Really, really nice presentation. Really amazing and cutting edge examples, I think, of technology and how health psychology really has a central role to play in driving this research agenda forward and working with people. So I really enjoyed this presentation and all of the different examples you were presenting us today. So yeah, at this point, I would like to open it up to the audience. Do we have any comments, any questions, any other thoughts on the presentation? Please feel free to unmute yourself or post in the chat. So we don't have any questions yet. People are probably gathering their thoughts. I know we have Felix up on the screen. Hi, Felix.
Hi, thanks, Jane. Thanks, Sebastian. Really interesting presentation as always, Jane, and I really liked the stories that you told us. I think that really helps us to sort of appreciate the complexity, but also the potential of this approach. I wanted to ask about the how we can sort of safeguard the longevity of some digital approaches or innovative technology approaches. So, for example, thinking about Dave, I can imagine Dave at the big, you're entering the hospital. Dave is there, and the first time I see Dave, I respond to him because it's new, it's different, and it's enrichment in my environment, which is otherwise pretty standard. But then each time I pass Dave, more and more times, I'll probably start to ignore him because I know what he's going to say. After a while, if there's lots of Daves all over the place, there's a risk that they just become part of the furniture of our sort of healthcare environments. And I think the same could be said for some other sorts of technologies. I mean, VR really hasn't taken off still, despite I'm a keen adopter, but no one else seems to really use it. And I don't think we've yet seen a real purpose for it, which would promote mass adoption. I guess I've got two sort of, well, it's a comment and two potential questions. One question is, how can we sort of predict what is going to, perhaps have that novelty effect and then potentially wear off? And is there anything we can do to sort of safeguard that? I suppose that's my sort of observation. I was just sort of thought going around my head after I was listening to you talk.
It's a really good question. And in fact, when I spoke to the consultant who I worked on those projects with, Dave, he said, you know where Dave is now, Jane? Dave is in a corner of my office. He's already semi-retired because we've actually started working on projects with virtual humans. And he said they're easier to program. So I think you've raised two really critical issues. One is around sustainability. If we build things that require resources and we think about climate change, we have to think about sustainability from that way. But also, Felix, in relation to technology, nothing stands still. And we are, a lot of us, of a mindset around long-term sustainability. And we probably have to accept that that's not necessarily always possible because the world changes so fast. And that trying to keep something exactly the same when the whole world around is changing is not possibly feasible. And maybe in the case of the example you gave, some desensitization to technology is useful, but maybe reduces efficacy. And so we need to adapt the types of tasks or novelty of the task of the sustained robot, let's say. We reprogram, we use it for different uses, we're flexible. I think we need to be rapid and flexible in our adaptation to the way technology is going. which is one of the reasons you see such a vast array of research that I'm working on. I don't think I'll ever be using the same tech tools over time. Ironically, as you mentioned, virtual reality, we did work in virtual reality 20 years ago, and I had a student just do a project on it recently, and I feel, as you say, it hasn't moved on at all, but we're still having a look at it. So I think we need to look at sustainability in terms of climate change, what we develop and the resources that go into it. We need to look at efficiencies, but I think we need to be able to flexibly and rapidly adapt to the changing technologies and try to leverage them in a timely fashion, and maybe accept that they will keep changing and we have to change with them, and that maybe they're not sustainable over the longer term. A lot of that is out of our control, I feel. And we can look retrospectively back at some and say that didn't take off or didn't work, or I think this will really take off, and find that we're wrong. I think virtual humans are going to be a huge thing, but I may come back and be wrong, you know, but it's a really valid point. And I think also, not in your case, Felix, but certainly in academia in general, there's often a reticence to get the hang of something, to find that it goes out of fashion. We don't like that, you know. We like to hold an expertise and carry it forward. I think the only thing we can carry forward is our knowledge into different environments and try to adapt it to solve global problems with current technologies. At least that's very much the approach I take in my research anyway. And it is challenging, but I think if we can do that, we'll actually position ourselves very well to be useful in long into the future.
Thanks.
Excellent question and response. Thanks, Felix. I've got Dom here on the screen. Hi, Dom.
Hi there. Thank you so much, Jane. As always, I love your presentation. Really beautiful examples and really practical applications, which I think really set you off from some other scientists. So a big congratulations on your work. My question is about health psychology as a discipline. So you said quite a few times that you were the behavioral scientists who are joining the team of tech developers, who are joining the team of designers, or malaria experts, etc. I wonder if you could give us some suggestions in terms of how do we promote behavioral science? How do we almost sell ourselves to other disciplines to convince them that we are really needed, that we are very useful, and that humans should be in the center of the tech design?
That's a really good question. And literally about 10 years ago, when I took my first trip to Florence to the ICT, Information Communication Technology Horizon 2020 get-together meeting, 6,000 people were there, and I was one of the very few psychologists. I didn't know much about Horizon. I was on my own. I was quite nervous. I worked the room. So one of the things I had to do, and we all need to do, is we need to listen to the problem that people are trying to solve. Listen carefully, because inevitably there's a problem they're trying to solve with technology. And once you start listening to the problem, if it's health related, we're already more in our comfort zone. So maybe the question then for you would be, where do we go to start these conversations? I think where we have incredible traction is to go into an environment. I think I said this to you before, Dom, at a conference, that where we are one of the few psychologists, we're the niche, unique discipline. So we already have a huge advantage in that space because there's a need there, or we're unique in the. So when the discussion begins about solving global problems using this technology, one of my strategies is you take a microphone and to ask a question, and you say, hello, my name is Jane Wall from Galway, or that's really interesting, the problem you're trying to solve. We've done work in this domain. Have you ever considered incorporating stakeholder engagement? Or, we found that's very effective when it's used in this way. If you like, I can help you with this. If you want to get in touch, here's my card. I'll send you some papers that might be useful to you. Because what's most important on these teams is that you engage with the problem. You leverage your abstract reasoning and creative thinking and your knowledge to help them solve this problem. There has never, ever been an environment I've been in where I haven't thought I've something useful from psychology that I can offer in this scenario. And when people see that, they're very grateful, they're very pleased. If you explain it well enough, they'll say, wow, I don't know anything about that. We really need this person. And this is how you build capacity. So how you get in those environments, I've said it before, a bunch of psychologists in the room together are no good to anyone. We're all fantastic, I know, but you're going into the arena at the coal face where people are developing the technology or trying to solve the problem. And one tip, and you're already really good at this, but say this African project, how did I get involved in that? 10 days before the deadline, scientists from Paris contacted me. They said to get funding, they needed a digital health component. They said they Googled and my profile came up and that they were really impressed by it. And did I think this was something that I could help with? Didn't know anything about malaria, hadn't been to these regions in Africa, listened to the project, went, that is such an exciting idea. Absolutely can help with that. Wrote the work package in a week, knew the project would get funded, especially with our input, and here we are. So at every stage, I said, that's really interesting. We can absolutely help. The gaps in their knowledge was so huge. It was easy. And that's how you do it. Yeah.
Amazing. Thank you.
And you have to be a bit of a risk taker. You have to have a bit of self-belief. We're such a strong group, the health psychologists, unbelievable. You know, from EHPS, the fantastic research. You know, you need a very particular kind of robust mindset to be able to survive the environment where you don't know all the answers. As academics, we're uncomfortable. You know, we don't like sounding foolish. If you're in an environment where you're the only psychologist, you're a genius in every environment. So you can't go wrong.
Great. Take confidence in your field.
Yes.
Thanks, Dom. We've got another question coming through in the chat here by Aminul. So thanks for the question. What were the difficulties or the difficult parts of your project orienting the providers and patients as a system user? So mainly around the implementation phase.
Yes, that is a huge issue. There's a couple of key things that will, and of course, Sebastian, you're more expert on this than I am. There's a couple of key things that will facilitate successful implementation. And it's the stakeholders being involved from the beginning. A key decision maker who's maybe a manager or of the frontline workers on the ground, who has got a good and non-threatening manner of engaging with and getting people on board. You need that person on your team from the outset. In all of our teams, we have PPI and stakeholder element prioritization exercises, a sort of a shared understanding of the difficulties, a shared problem-solving approach, and then looking at acceptability and barriers and working together around them, and then looking at how it's deployed on the ground. So, for example, with the robot in the diabetes unit, the guy that I work with there, he's Professor Derek O'Keefe. If you ever have time, look him up. He's Professor of Medical Devices. He's an engineer who trains as a doctor. He's a consultant endocrinologist, and he is a kind of geeky engineer who also looks after patients. So he loves the toys. He's a fantastic manner with patients. He's got a great manner with his staff, and he's a fantastic academic. So when he tries things out in the hospital or patient unit, there's an element of trust established, which is why I call this lecture Trust and Technology Terrorism. You have to take the fear out of it. Who's prescribing, you know, the digital intervention? Is that a trusted source? If they prescribe a pill or if they prescribe a Fitbit, are you going to buy in, you know, and do they have the education and capacity to educate you, the patient, in a non-threatening way on how you can embed this device as an enhancement of your care, communication, and your self empowerment to self-care? So this is the big barrier. We do it in small pockets. In terms of wider rollout, I believe actually the community and more local based ones are by far the most successful. So many of my projects were based in the community with strong buy-in. I've had adherence on our cancer project of 95% to using Fitbits in Donegal, in the northwest of Ireland, because we buy in from community. I don't think rollout works. I think what you need is a template that can be adjusted culturally and personalized, and the principles are utilized and adapted. And I think this is where AI can actually assist us, because large rollouts that are depersonalized don't really work. We disengage, but that's a challenge. But when we see successful templates, it gives us hope that these can be adapted despite huge challenges. But the key method is through strong community buy-in and engagement. And that, as we know, takes time. That's a critical component of every project.
Yeah, great question and great response. Perhaps following up from that, you talked about getting that initial stakeholder buy-in, early on in the project to really get them on board and so on. I was just wondering, in your approach, and it seems like stakeholder engagement is really central to all of your work. Are you usually very iterative in that? And how do you take that information from the stakeholders and translate it into the technology? How do you go about doing that usually?
Brilliant question. So when I wrote the work package for the African project, and I mentioned earlier, I wrote 2 deliverables. One is collective intelligence, which is a very strong stakeholder engagement, understanding the needs. And this is going to be one of the elements that feeds into the development of the digital device. The second deliverable that I wrote into the project was a digital health strategy, which was quite funny because we all looked at each other on the team and we said, look, I've never written a digital health strategy. Have you? No. Okay, sure. So it was a first time writing one. And what we tried to think about it from a very practical point of view, which is how can we take everything the Ethiopians and the Madagascars have taught us? How can we then take everything we know about health behavior change, the BCTs, and everything we've learned, the problem we're trying to solve, the behavioral dimensions, and how can we merge these into a protocol that we can give to our co-partners on this work package, who are kind of the app developers, that they can develop something that's going to work. So in parallel, the app developers are doing scoping exercises independently of us in Africa and Madagascar, while they do more towards taking what we have, but trying it in the kind of talk aloud. What do you think of this? On the ground, are we getting connectivity, and do we need to alter the way our device is looking? So all of that information will be merged into the development of a system that we know takes into account everything we've been told from our collective intelligence workshops. In those workshops, we had patients, we had community healthcare workers, we had the medics that do the test and trace, we had the academics, we had everybody. We said, we all need you to work together to give us some useful information because you're the ones going to be using this. And then we did digital health strategy, taking best practice and all of our psychological knowledge. And then we have the app guys on the ground. So no one's ever done this before, So we've used everything we know. We may have left things out. We tried to get opinions from anyone who could help us. We've taken a very pragmatic but evidence and scientific based approach. And we're going to be looking at all of the pilot testing of this and how it works. Is the 5-year project. So I'll get back to you with future updates on that, Sebastian. So I suppose we've used as much common sense and expert knowledge as we can manage and try to weave it together in a coherent plan that a technology developer can actually understand. And this is not the first time we've done that. And often it's just a simplicity that's going to be critical in getting something that's workable on the ground. And we will be following up and trying to learn about, what we did wrong and what we did well in due course.
Yeah, really nice. So it sounds like sort of the stakeholder engagement or the kind of collaboration was not only with the stakeholders, the users of the technology, but also really good communication and collaboration with the project partners and trying to really translate that knowledge from one kind of stakeholder group to the next and work together to come up with the solutions. I like that. Really nice.
Yeah.
Do we have any further questions here? Anybody would like to, last chance for a question or any comments for Jane? I think this has been already really nice conversation, some really good questions. Okay, we don't have anything else coming through. Oh, Felix is back. He's using the chance.
Good man,
I thought I'd
Felix.
take the opportunity, but if anyone else has a more burning question, please do jump in. But I was also I wanted just to ask about the AI taking our jobs, or robots taking our jobs kind of issue, because it's a really interesting one, and you made a really good point about what did you call it, low skill tasks, and sort of nurses and other, as an example, where they could spend more of their time doing higher skilled tasks and perhaps what we would call the important stuff. I was sort of reflecting on that, and one is that, can we always work at that level of the high skilled tasks? Do we need sometimes those low skilled tasks to kind of decompress a bit? Or is that sort of like easing some of the the pressure a little bit? And I don't know, maybe that's incorrect, and it'd be good to know where people can just operate at that for those higher sort of skill tasks all the time, and when actually people need a bit of a mix. And the second bit is that, will our politicians and governments and would they actually see that if we were able to replace some of the low skilled tasks with automation, do you think, or what the risk would be that they might see, great, this is a cost-saving activity, we don't need as many nurses, or whatever the profession is. Now that's the bit that people are worried about. Now if we could kind of collectively agree that we would still need the same number of nurses and other things, so that we could do a really great job and actually start to bring down the waiting lists and all these other kinds of perennial problems that healthcare systems will experience. So I don't know if it's a question or a thought, but I guess that's, there's those two aspects of it, and how, to what extent do people, are they involved in that conversation about having some of their tasks taken away? I mean, I'd love some of my low skill tasks taken away from me, but maybe I'd need some of them still, just to kind of be able to have an easy day occasionally.
Yeah, very good question. And I think, us as academics, sometimes we like the mindless stuff because we feel our brains are burning from thinking too hard about complex topics. You'd really, it's a very good question. It'd be well worth sitting down and talking to nurses. It might be like in academia. Sometimes you think, what, I'd rather be a research manager than actually think about the big problems. And it's probably the same in their profession. But most of them would be driven into the profession because they want to care for patients. So when they can't do that, the frustration grows. And it might be the case that providing the technology opens up opportunities for people to play to their strengths and do the things they prefer. And that may be still low skilled, in which case they may rethink, their profession also. But for most people, they'll say, I just want to care for patients. And that takes me away from that, especially when patient care is substandard, is very disconcerting. The second question you raise is really, really interesting. And it's one we worry about in academia ourselves, which is, at what point do we become defunct? But in the end of the day, and I think this is another exercise, and not one we're responsible for, is demonstrating the efficacy of what the nurses are doing. Does it matter, that if they talk more to patients, that it will reduce waiting lists or improve self-care or whatever? I mean, there's endless research that shows that is the case. And I suppose if they had to do assessments or performance reviews or whatever to justify, if they felt they had to justify it, then maybe that's something they need to do. But I think the evidence is really strongly there. And the satisfaction of the workforce, reducing sick days, there's lots of metrics you could leverage there. So in the end of the day, rather than people being concerned about losing jobs, you've highlighted where the weaknesses in the system are already, which is endless waiting lists. We have a growing aging population. Our care is not up to the task at the moment, and we need clever ways to improve that. So I think that's the approach that should be taken. I don't think it should be threatening or intimidating. And I also think if it opens options, if you're a nurse who'd rather be trekking up and down to the storeroom because you've decided you're not really that keen on looking after patients, it gives you an opportunity maybe to do that or rethink your profession. But I would suspect most nurses or doctors would say that they'd rather operate to the higher level. It's what they trained for, But yeah, very good question. And it's good to expect and consider these other factors in the broadest sense when we're conducting this type of research.
Thanks, Jane. And I, for one, can't wait to meet Dave in a healthcare setting.
Oh, he's fab.
So
yeah.
hopefully he'll arrive soon. Thanks.
He's cute. You like him.
Hopefully he will come with a nice Irish accent.
Yeah, exactly. I will pass that on.
Okay, well, let me thank you again, Jane, for the brilliant presentation, and thank you everyone for coming along and for the questions and contributions. So yeah, thank you and enjoy the rest of your day.
Thanks a million, everybody. Take care.
Bye now.
Bye.